even though it is not a very interesting subject, but I want you all to understand there is a department exists. So many people, like many are not aware, there is a normal patient and a blind person. In between, there is a large gap. Usually they are neglected. So they are called patients with low vision. By paper, by book, the better visual acuity in a better eye is 6/18 to light perception. Visual field of 10 degree from the point of fixation. They are called patients with low vision. So prevalence is increasing year by year, but the cause may vary. As discussed earlier, even here, it depends on the cause or the disease prevalence. Each decade it is varying. So whenever there is some disorder, either it can be infection, inflammation, or degeneration, or tumors, so it affects the structures. So there are anatomical changes. Then goes the functional changes. It is visual acuity, visual field, and contrast sensitivity in case of eye. So then it impacts the person's skills or day-to-day activity, like reading, writing, daily living, or mobility. Then we name them handicap. Then the socio-economic consequences occurs. They will be isolated. They become dependent. So what is functional vision? In those days, it was called like whatever residual vision was left, we have to preserve it. It is called functional vision. Now, functional vision is gone beyond the visual acuity. It is more of involving the brain. It is visual acuity and the skills are interconnected. So whatever vision the patient is left with and whatever skill that patient is left with, we have to coordinate both this and make the best use of it to give a better quality for that particular patient. So visual skills used for functional visions are awareness and attention to objects. It is not just the reading of Snellen's lines, tracking, scanning, discrimination of objects, discrimination of details of the object, and identifying and perception of patterns, words, and numbers. Challenges peculiar to children, as you all aware, like they are not cooperative, and their emotional and psychological impact is vary. And to get adapted to a new place, it takes time. I think all the pediatric ophthalmologists will agree. Sometimes it takes many visits for us to assess whether the child is normal or blind or left with some vision. So because many factors are interrelated. So 2 decades back, the scenario was different in India. Now, when we retrospectively look at our data of what are the patients coming to low vision clinic, it is mostly children with cerebrovascular insult, apart from the ocular condition. In those days, like 2 decades back, nutrition was the main factor, like Dr. MRV said. So now it's changing like Western countries, because obviously when the preterm children can survive a 500 gram, 600 gram born child, we are making them survive. So definitely they will be left with ocular and also cerebral accidents. So CVA is the most common vision impairment in children, both in developed and developing countries. But it is not like this disease will follow a pattern. They may show different strength and weakness depending on the pathology and which part of the brain is affected. So it can be temporary or permanent. It can cause severe visual impairment or blindness also. So according to Hoyt, we are moving from ocular blindness to brain blindness. Can one of you read this? Everyone can read this, no? So even the letters are projected jumbled. A normal person means with the brain, normal brain, we have some visual memory. So we can read it normally. But a person with CVI or autism, even normal letters can appear like this. That is what we have to understand before going in for ophthalmic examination of children or adult with CVI. So vision and development does like milestones, general milestones, we have visual milestones, but 100% it cannot correlate. Normally, according to the book, they say 3 months fixing and following the objects, specifically mother's face. But now we are seeing some children at 6 weeks itself looking at the mother's face, looking at the iPhone, watching the video. So we cannot just say it is normal. Maybe that is also abnormal. After a few years, we may say premature visual maturation. There may be one entity, so we don't know about that. But normally, child, when they develop head holding, they start fixing and following. Until then, we can actually wait. Some parents get panic at 3 months, 2 months. My child is not looking at my face. But need not bother until 3 or 4 months old, until they attain head holding. If that is also delayed, then we have to be concerned. Sometimes that be delayed visual maturation. It can be like with the brain damage or without the brain damage, which is unexplained, they develop little slowly. So we give a frequent follow-up to understand this. So visual acuity, no child is born with complete 6/6 vision or fusion or accommodation, whatever category you're giving or whatever measures we are giving for visual acuity, it is by stages. So we have to understand before giving started our evaluation, we have to be thorough which month, what we can expect from that child. So apart from the routine evaluation of any pediatric patient, few important things are visual acuity is very difficult to measure in these children. Then even if we measure, we have to check for other aspects of visual acuity, that is contrast sensitivity. So these are charts, Heidi chart. It is with the contrast grading, it is there. So it depends on fixation preference of a child. We use this chart. And same, the principle, we use the Leah grating symbol. It also measures the vision. And this is mailbox. Usually the horizontal child with the sound brain, even if the child is holding the small paper, either horizontally or vertically, when coming near to that object, it changes the position according to how the gap is. So it posts this, it's like a post box. So the child has to put that paper inside that gap. So if it is vertically presented, you give the child in a horizontal manner. When they come close to that box, they change the direction, post it. When the child has some issues, whatever shape you give, they will be holding in the same way. Here, if you're holding in a horizontal position, the child will be trying to post it in a vertical manner. These are few tests to assess the shape, size, and whether their awareness to the object, all that. So this is something like visual awareness. So child will be able to track the light. These are all rough measurements of vision. So it is very, very important to intervene very early in life because nearly 85% of child's early learning occurs through vision only. So children who are born with blindness or low vision are at a greater risk of developmental delay. So according to Karen, he has given 5 important principles when dealing with the young low vision patients. Encourage socialization. Encourage development of compensatory skills. We always say when a person with blind, they have some other sharp skill. Many people will sing. Many people are good at artistic thing. You have seen why the chair has to be, you have seen wiring of the chair, always done by a blind person. Nobody wants to do it. I don't know. But they have special skills. So identifying their special skills and utilizing it is very, very important, and provide realistic feedback to them, because they are totally unconnected with the world. They don't know what is realism. So do not praise them unwantedly. Tell them what they are doing it, either correct or wrong, and convey high expectation. Never overprotect, because they have to carry on their life independently, and promote opportunities for work. So when we are intervening, the surgical part or medical part is completed by the doctor, and rehabilitation is take over now. So they utilize what is remaining in the cup. So when to start LVA actually? As early as possible. Even when the child is not discharged from the hospital, a preterm child, they are going to stay in the hospital for 1 month, 2 months, 3 months. If you find to have nystagmus in the child, we can start the stimulation early. If you are finding optic atrophy in the child, it is important to do dilate function. Anyway, we will be doing for preterm infants, dilate fundus examination. If we find to have optic atrophy, then we have to start stimulation even at that stage. So again, visual stimulation can be done by lights with the objects, or even books with the colorful diagrams. Each stage, whatever the child is capable of, we have to stimulate. Coming to the broad classification, environmental modification to be done at day-to-day, because they have to live in the school or at home. Next is low vision devices. Mostly till date, it was optical devices. Then comes the not optical. Now latest is electronic devices. So principle is either you magnify the object, move the object closer to the eye, or enlarge the physical size of the object, or angular magnification using the optical system, or electronic magnification. In those days, I don't know, our grandparents have told, we have had books of our mythological books, even the Bible or Quran, everyone, like one copy of bold letters was there. It is meant for old people. Those days, there was no presbyopic glasses. So they used to have a large print books. Now, there are a lot of devices available. So it is single vision spectacle. Mostly children, we prefer to give for children this one, because they don't need any hand to hold this, because we have to assess that also. People with tremors and children who cannot hold the magnifiers, we have to go for single vision spectacle magnifiers. Then there are a few handheld magnifier normally used by the Goldsmith, but we can give for people with low vision, especially for older patients with ARMD and diabetic retinopathy with macular scarring. And stand magnifier in case of if they are not able to use their hands. So for distance, actually, there are only very few devices. For a very long time, we had a magnifier. This is much better. A telescope, which will be like child can only look at the distance. If they want to shift from distance to near, it will be very difficult for them. So, and it had a lot of restricted field. Now, it's much, much better. They have bioptic telescopes, which is very sleek. The patient can look through their glasses, and just with the movement of their head, they can look through the telescope. So they can, it's like a win-win. They can use both the systems together. So coming to contrast, you all know albinism patients, how much they will suffer, and also patients with aniridia. So the filters will be very, very useful for them, and also just giving a cap for them. And always remember albinism patient, how they have to take care of their skin and everything. Apart from that, we can give a hat. When they go out, they can use a umbrella. Coming to electronic devices, this is a closed circuit monitoring TV. It is just keep a book down and it enlarges the print and show it. now we can magnify it with our all the iPads, and there are a lot of devices available for magnification, but for a very long time this was used. And these are some softwares which helps to magnify the screen. And this is not for very small children, for older kids and for adults who have uh, hemianopias, field defects, prism glasses can be given. These are some non-optical devices which helps in following the lines. So this is a signature pad where just keep it and sign it in the center. Otherwise, it is very difficult for them to follow a line. So one child, 16 years old, came to me recently from the disabled school, and the teacher told me the child cannot see for near. She said she has very poor vision. Whenever I give something, she goes close to the book and write. And it's difficult for her to write. So when I saw, I put the torchlight. She was ortho, no nystagmus, no squinting. I didn't even dilate that patient at that point of time. But she cannot communicate. And she was a CVI child with a microcephaly. She was just giving me an innocent smile. So I thought before making her write, let me try to check her vision. I told her I'm going to give her chocolate and showed her, all of you have seen the cake decoration, no? Immediately she gave one big smile and she just picked up the cake decoration. I told her you have to sit straight and pick up the chocolate. Otherwise I will not give. So she nicely picked up. So when they pick up the cake decoration, the visual acuity roughly 6/24. So the teacher was so surprised. Then I thought I will make her write and see. Then I failed. She gave me a sarcastic smile now. She again goes close to the book and she started scribbling something. They gave her some alphabet to write, nothing happened. Then I put a line for her to follow. I made her sit straight, again follow the line. She was unable to do. So we can see the difference. Then I had to teach the teacher, her visual acuity is better, but writing skill is different. And following the line, it is very, very difficult for them. Most of our alphabets, we have to, either it is straight or round, we have to follow it. So she cannot do that. So we have to always increase the illumination, even at home, even putting lights in the staircase for them to walk, especially for RP patients. And wherever they are using, like their closet, even when they're sleeping night, if they have to get up, it is very difficult for them to adjust. So wherever possible, we have to increase the illumination and increase the natural light. And if they have glare, we have to reduce it by putting some curtains like this. So I'm using the contrast for children. See, this is a black plate with the white food. Then it will be easier for them to take it and eat. So giving them contrast things is even for walking and for books also. So this will be very useful. And giving them safe environment. When wherever they walk, there should not be any spillage of water, not only for blind patients. All CVI kids, they have problem in inferior field. Always they tumble on things. They cannot look down, either because of the field defect or they are unable to rotate their eye. Even the movement is normal, the command is not coming from the brain. So they are not able to look down properly. So these are the few things which are very helpful. Tiffany's template is for assessing the coin size and their rupee note, they can judge. These are the latest devices for blind people. This is a smart cane, which actually there's a sensor is there. Whenever a person come across an obstacle, it actually vibrates. So they can stop and they can deroute actually. And this is a smart vision glass, even though it is expensive and it is undergoing so many modification now, it is not freely available in the market. They have 5 commands in the sensor. So once, if you press one, it will help to identify the object around. It is very interesting. Either the computer is the laptop is kept in front of you, it is on, it'll give that commands. It's a oral information that it'll give. If a person is sitting in front of you, it'll assess how old is that person. 30-year-old man is sitting in front of you with a smile. And next stage is reading mode. They can read actually. Then third one is a walking mode. Again, like a smart cane, it helps to find the obstacles. Then fourth is help to identify. So familiar faces, familiar objects, we can actually record and keep it. So it will say next time when the patient sees that person, then it will give, this person has come. He's sitting 15 feet away. He's coming 15 feet away from you. Something like that. It will give like a memory. So it memorizes the objects and give, because it's mainly for them to avoid the strangers. So always we have to communicate to the teachers how the classroom seating, avoid glare on the board, dark pencils and bold notebooks and pencils has to be used. And older kids have to start mobility training, and computer training is available by many voluntary organizations for the visually impaired. Especially we are working with a Vision Aid. They are like, they are doing a lot of work on this, and they help us to give computer training for these children. So integrated education is including these children in normal schools. There will be one special trained teacher, but including them in the normal system is very important, because our part of the world, we are not used to considering disabled person as normal. So we treat them indifferently and we don't know how to treat them. Sometimes we suddenly jump and go and help them. It will actually make them nervous. So when they grow with the normal children, from childhood, normal kids also will know when and where the disabled people need help, and accepting them normally will make them like, they will not be so dependent on others, make them also independent. So we have to consider these important factors: good knowledge about the disease and patient's history. And most of the time, like, we should not be taken for granted it is congenital. Many times acquired can get missed because parents noticed it later. So imaging wherever possible and wherever needed, we should not hesitate. All syndromes and all babies who have had admission in NICU have to go through the regular evaluation. So early identification, early intervention, and early rehab, we can make them near normal. Thank you.